Welcome to the show. We share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Kim Puterbaugh. She is an obstetrician gynecologist, and we're going to talk about her Kevin MD article, Post-Row, Miscarriage is More Dangerous. Kim, welcome to the show.
Thank you.
We'll get into your article in a little bit. First off, briefly share your story and journey to where you are today.
I am actually a little bit of an unusual person in that I am doing exactly what I wanted to do when I was a kid. I wanted to be a doctor when I was 10 years old. I actually went to church with my parents and heard a missionary doctor speak about working in Afghanistan, and I looked at my mom and I said, that's what I want to do. And I took a little bit of a time to get there, but I ended up doing exactly what I wanted to do. Initially, when I went to medical school, had a National Health Service Corps scholarship. I worked in Appalachia for about 8 years. And then I came back to academia and I worked at University of Wisconsin and was an associate program director there. And then I came to the Cleveland Clinic to be an OB hospitalist, which at that point was a new field. I had always been a generalist before and done full scope OB/GYN. So I became an OB hospitalist, and I had always loved obstetrics, and it's a newer field that kind of allows people to do obstetrics later into their career. And then I moved to University Hospitals to become the program director of their OB/GYN residency program. And I just finished up last week as the president of the Society of OB/GYN Hospitalists. So we've actually become the largest subgroup of OB/GYNs after generalists. So it's a field that's really growing quickly, but is still pretty young. It's been an exciting ride getting here.
Take us into a day of the life of an OB hospitalist. What's a typical day like for you?
We work in my institution 12-hour shifts. Some people work 24-hour shifts. And so we take care of everyone who comes in the door. So if a patient comes in who has a doctor, their doctor may be in surgery, their doctor may be in the office, and we evaluate them and get in touch with their physician and let them know what's going on. And depending on the model, a lot of times we do all the deliveries in the hospital. We supervise midwives and we work with medical students and residents. Also, we take care of all those patients who either don't have a doctor at all, or maybe they have a physician in a different hospital system. So we just are the people who are in the hospital and deal with normal pregnancies, but then any kind of emergency that occurs, we're the backup for all the physicians on the unit. So we get called in for hemorrhages and shoulder dystocias, that kind of thing.
So I'm a primary care physician, and ever since the advent of the hospitalist movement, I'm primarily seeing patients only in the office, and I rarely go into the hospital to see those inpatients, and of course leave that to the general hospitalist. Now, do you see that trend also being replicated in the field of obstetrics gynecology, where eventually they'll have one group of obstetricians, gynecologists in the hospital and another group who just practices in the office?
That is the thought that the GYN subspecialties will be one area, office will be its own sort of specialty, and then inpatient obstetrics would be another. Part of it is that things change quickly in inpatient obstetrics. Our emergencies occur over the course of about 4 minutes. So we need to respond really quickly. So the days when I used to be in the office and get called and have to run across the street to the hospital and run up 3 flights of stairs and that kind of thing just aren't really considered the standard of care anymore. So being on site and really being the leader on the unit is the trend going forward.
All right, let's transition and talk about your Kevin MD article. It's titled Post-Row, Miscarriage is More Dangerous. Now, for those who didn't get a chance to read your article, just walk my audience through it and share the story why you decided to write it.
I realized when the Dobbs decision came down that the implications were much broader than a lot of people realized. Obviously, abortion is a very hot button issue, and people have very emotional and personal and religious reasons for their beliefs. But as a physician working in a hospital who deals with emergencies, I realized that the impact of this law was far beyond maybe what people understood. And so we found that women coming in with miscarriages, now there's a lot of uncertainty on what we are allowed to practice as quality medicine. So we are required by federal law to practice safe medicine and provide emergency care for everyone who comes in to our hospital. So if a mother comes in and she's bleeding from a miscarriage, or she's getting infected from a miscarriage, there's now a lot of confusion on when we are allowed to intervene. There's a recent article that came out in what we call the Gray Journal, the American Journal of Obstetrics and Gynecology, about the impact of Texas Senate Bill 8 in Texas. There were two hospitals that observed what happened after that law went into effect, and there was a significant increase in morbidity in mothers who were told that they just had to wait until they were in more danger before we could intervene. So it's really putting the life of the mother at risk for a pregnancy that's not viable. I wanted people to understand that this isn't just a philosophical issue. This is something that we deal with every day, every night on call when moms come in with miscarriages or ectopics, trying to make the right decision for them medically based on science and evidence-based care rather than emotion and political sound bites.
Now, can you take us into that decision-making process? Maybe talk about a real case or a hypothetical case where a mother would come in bleeding, perhaps from a miscarriage. Take us into that decision-making process and some of the obstacles and decision points that you have to face in this post-Roe world.
Example that comes up not infrequently is mothers who break their water very early in pregnancy. So 16 or 17 weeks, they're still months away from having a baby that can survive. And once their water is broken, they are at significant risk for infection. And if left untreated, sepsis, which can lead to multi-organ failure and death. The recommendation in the past has always been to counsel the mom. And if she wants to continue the pregnancy, she has that choice. Or if she wants to terminate the pregnancy at that point to save her life and to preserve her future fertility, she always had that option. Now, if the fetus still has a heartbeat, it is a much more complicated procedure to verify that she qualifies to have a termination of that pregnancy.
So let's say someone comes in the middle of the night and you're on shift. Who do you turn to discuss the pros and cons? Take us through that thought process, because you did mention that it's such a difficult decision to make and there's a lot of confusion around it. So take us, what would you do in that situation, say in the middle of the night?
So I want to be clear that in my mind, it's not a difficult decision. From the day I started this profession, the life of the mother comes first. That's the absolute bedrock of obstetrics. And these political complications make the system more difficult, but in some ways it doesn't change the equation for me. I still provide the best quality care that I can. So you look at the mother, you look at her vital signs, you look at the labs, you decide if she's severely anemic, you decide if she's infected, you look at the lactate, is she septic, you look at her fever, all of those things that we all do as physicians. We know how to do this to determine if someone is stable or becoming unstable. Sometimes we repeat labs, all of the things that we all learned how to do throughout our whole careers. And if it turns out that we get to the point where we decide that the mother really needs to move forward, and in counseling her, she agrees that she wants to move forward with terminating a pregnancy, that's the piece where it becomes a little more complicated. So that's the piece where we need to get our administrator on call involved and our legal team involved, just to make sure that our documentation meets the standard that we want for the laws in our current state. And the laws are also changing. I'm in the state of Ohio. There's several bills in front of the Ohio legislature which would change what our requirements are again. It doesn't change the federal standard of care, so we're caught a little bit in the middle, but we do want to keep in touch with our legal team and make sure that we're compliant as much as we can be while really putting the health and life of the mother first.
Now, are there any cases that you've heard where patients were actively harmed in this post-Roe world because of this additional decision-making process?
Yes. So if you look at the article, the AJOG article that came out of Texas, there was a significant increase in maternal morbidity. I would have to look at the numbers again, but I think it's in about the 20% range of severe maternal morbidity in terms of needing blood transfusions and IV antibiotics and hospitalization because of the management of miscarriages. That we have been doing at least 1 in 5 documented pregnancies end in miscarriage. People think that up to 50% of all conceived pregnancies end in miscarriage. So this is an incredibly common thing that touches most women in the course of their reproductive lives. And so not being able to manage them as effectively and safely as possible is really a hindrance to the quality of care we can provide.
So, in practical terms, what kind of delay are we talking about? Because you had to get the administration involved, get the legal team involved. And from a practical standpoint, how long does that delay care?
So in our institution, we can do that quite quickly. We don't have quite the same laws in Ohio that Texas has. That it seems from that article that a lot of people were discharged from the emergency room and told to come back when they were having more bleeding or were more infected. And that caused delays of days to even weeks. And that's the situation where you can get into impacts on fertility and impacts on the mother's health.
Now, is it implied that the medical decision making then was affected by this law, leading to the advice to perhaps come back?
Yes, absolutely. That there are penalties to physicians for intervening if there's still a heartbeat on the baby. There's the bounty hunter aspect of the law that anyone who aids and abets the termination of a pregnancy can be sued by bystanders and that sort of thing. So I think it just created a lot of anxiety and confusion in the medical staff in Texas. Fortunately, we don't have that aspect to our law, but those are some of the things that are in front of the legislature now.
Now, off the top of your head, are there any specific cases where you have some of these consequences against physicians?
We have not had any in Ohio yet. I think the question is going to come through Texas first. If those $10,000 fines by bystanders will be implemented, it's really a shocking change to the American legal system because it's the first time that the mother has to prove that she didn't have an abortion rather than the accuser proving that she did. So it's a very disturbing turn of events, even beyond the whole abortion question that we've gotten thrust in the middle of. One of the things that I actually have been really proud of with my colleagues in OBGYN is it's really galvanized OBGYNs to speak out collectively. I think as physicians, we tend to kind of practice as lone wolves. We like to make our own decisions and move forward and make our own treatment plans. But I think this has really pulled a lot of people together to say that this is not appropriate for our patients. This is not the care that they deserve, and to really speak out.
We're talking to Kim Puterbaugh. She is an obstetrician gynecologist. Her Kevin MD article is titled Post-Roe, Miscarriage is More Dangerous. Kim, what kind of advice do you have for obstetricians, gynecologists to practice in this post-Roe world?
So my recommendation would be to practice quality evidence-based care. At the end of the day, doing the right thing is the right thing. And if there's a law that makes that more complicated, we still owe our patients that duty of care. I also think, like most things in America, this falls most unevenly on our most vulnerable populations. I certainly think the decision-making process that people make for Black and Brown mothers is somewhat different than for wealthy suburban white moms. So making sure that people have access to care and can come back if you're sending them home from the emergency department, make sure that they have transportation, make sure that they can come back in a timely manner so that they don't have a really severe complication. I actually had a patient early in my career who was miscarrying. She was 15. I had a very long conversation with her mom, and we had a plan in place. And she was coming in, she was stable, and she was coming in for a scheduled D&C on Monday morning. And this was Friday, and we had the whole plan in place. She had all of her warnings in place, so she knew what she was supposed to come back for. And she ended up coming back having really hemorrhaged and having a hemoglobin of 5. and needing blood transfusions. And I said to her and her mother, what happened? Like, I thought that we had this plan in place. And it turned out her parents were divorced, and she went to her father's for the weekend, and she didn't want to tell him when she started bleeding. I think that the people who are the most vulnerable will be the most impacted, and we need to make extra sure that they have access to care when these barriers are in place.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
At the end of the day, we know how to take care of people as physicians. We know what the standard of care is. I always feel like it's better to do the right thing and defend that than to do the wrong thing and argue about it later. I think our patients need us more than ever right now. And there are resources if you are struggling with patients that have septic abortion, which is something we had not seen a whole lot of when Roe was in place. There are resources. The Society of OBGYN Hospitalists can help with that. We actually did a big simulation to help people know what to do and make sure that women are getting fluids and antibiotics and things in a timely manner to save them. And just reach out. I think the more collective voices we use, the better. And our voices as physicians are the informed ones in this debate, and we should be the people making the statements rather than politicians who really don't understand the collateral damage that this is causing.
Kim, thank you so much for sharing your time and insight, and thanks again for being on the show.
Great. Thank you so much.